All right, hello everyone. As you probably saw from the agenda, we have a pretty full presentation. We have several of us are going to talk about some various aspects of both basic and COVID-19 related ICU care. I am going to lead off by talking briefly about sedation in the ICU. This group obviously knows more pharmacology and pharmacokinetics than the average intensivist probably. So I'm not going to spend a lot of time on the drugs or the doses or all the stuff that you guys know. I'm just going to point out some basic contexts that I think are important to think about when you're in the ICU. The context in the ICU is a little different, obviously, than the OR. And I often have to remind residents, for example, that are just starting on their ICU rotation that patients in the ICU, including patients who are intubated, including patients who have open abdomens, including patients who have quite a bit going on, rarely need a real general anesthesia level of sedation. The caveat being, except when they do. And so just like the rest of anesthesia, our job is to try to figure out how to dose appropriately for the context. So some patients with severe agitation, patients who have a real high risk of death if they, for example, pull their tube out or decannulate their ECMO or stand up and eviscerate themselves with an open abdomen, may require higher doses of sedation. In particular, patients with status epilepticus who are having neurostorming after a severe traumatic brain injury, and probably most relevant, patients with severe ARDS may need deeper levels of sedation. Conversely, patients who are in extremis, in other words, in profound shock, who are not having surgery at the time, may not tolerate even minimal sedation or analgesia. Fortunately, I think for all of us and for the patients, most patients in this situation are unlikely to need that level of sedation, but it's something to take into account. Sometimes even a very small, bolus dose of sedation can tip somebody over the edge. In terms of general principles, I'm just going to point out a few things that I think are important. Many studies have reported measurable harm from heavy sedation regimens in the ICU. So basically, I'm not going to go into a data review because we don't have time for that, but there are a few studies that have looked at outcomes comparing light to moderate sedation versus no sedation. And some of those studies have suggested that despite what we were kind of starting to think, no sedation at all may not be superior, but is similar in outcome to light to moderate sedation. But there is really no significant study that's shown benefit to heavy sedation. So what we know about excessive sedation is that it lengthens ICU and hospital stays. It impairs the ability of your patients to mobilize, which can lead to lots of problems in terms of liberation from the ICU. It seems to increase the risk of venous thromboembolism. It increases the incidence of delirium. And overall, it worsens cognitive outcomes after critical illness. So, applying these general principles to your patient, I think it's always important to ask, why does your patient need sedation? What are you trying to accomplish? I just heard a text that you guys can't see the slides.
Everything's fine on the slides here.
And I think it might be a small problem. I think a lot of people can't see.
A lot of people can?
Yes.
Okay. All right. I'll pause for 1 minute. All right. Hopefully, people have been able to figure it out. So obviously, I think we'll try to make these available afterwards. So the question is, why does your patient in this case need sedation? Rather than just putting it on kind of, regardless of situation, think about what your goals are. You should always incorporate non-pharmacologic strategies whenever possible, meaning sometimes using restraints, soft restraints, having presence in the room of nursing and family. Obviously, that's an issue in the current situation. Remember that sedation clearance may be limited by organ dysfunction. As people get sicker, they tend to not process these drugs as well, but that may or may not matter. A lot of times it doesn't matter if the clearance is slowed if you're anticipating somebody's going to be on a ventilator for several days. The other thing to keep in mind is that delirium is a profound and important problem in the ICU, and delirium incidence in our patients is estimated at anywhere from 50 to 80%. It is strongly associated with increased morbidity and very real measurable increase in mortality rates when present. So your general goal is to use the least effective dose necessary to achieve patient safety. How you do that, we have two main strategies, and the main point is to try to use some kind of structured assessment or protocolized sedation algorithm to guide your dosing. So we tend to use RASS, which is the Richmond Agitation Sedation Score. And that basically just is a simple score, which is presented here, that ranges from very agitated and combative, which is a +4, to unarousable, which is a -5. And we tend to try to target something like 0 to -1 as an optimal level of sedation. From 0 down to -3 is considered light to moderate sedation, and that's a reasonable target for a patient who is intubated and needs more sedation. But the basic point is to target your dosing and your orders so that you are targeting the appropriate level of sedation and having nurse feedback and measurement of that. Now, obviously, again, this requires somebody being in the room to frequently monitor, which can be a problem in our current situation, but it's a general strategy we try to approach. And then the other thing we try to do is pay close attention to delirium, and I've posted the CAM ICU worksheet, which is just a simple screening tool to measure whether a patient is delirious or not, and it's designed to be usable in patients who are intubated. So whether they have delirium or not may not be something you can fix, but it's important to pay attention to it and to try to adjust your sedation to limit delirium as much as you can. So in general, there's been a real focus on this general concept of ICU liberation. And two of the key components of that are to ensure that every patient gets a daily spontaneous breathing trial and a daily sedation interruption. And the point of that is that if you don't test whether or not your patient can get by with a lower level of sedation, you'll never know, and you'll tend toward oversedation. So those things have been put together into an ABCDE bundle, which includes awakening. So A is spontaneous awakening trials, B is spontaneous breathing trials, and then C is A plus B plus coordination of sedation and choosing your sedation wisely. D is delirium assessment and monitoring. And then E is exercise and early mobility. So we want to start working on getting our patients out of bed. We're not very good at doing that here, but there are certainly places where patients on ventilators are ambulated as much as they can. And you want to, that's basically the point, is that's the goal. So you don't want to be over sedating people because you're just not thinking about it and you're just not checking whether they need the level of sedation they are at. In terms of sedation that we use, I'll just be brief. You guys know these medications. I've listed them with a couple sort of key points to think about when you're running longer-term infusions. So propofol obviously works as a pretty good single agent. One of the problems with propofol is that at doses that may be required to treat respiratory distress, you may develop significant hypotension. Obviously, if you run propofol infusions for longer than 24 to 48 hours, you start to become at risk for propofol infusion syndrome. Risk factors for that in particular are malnutrition, hepatic dysfunction, and exposure to steroids. And this seems to be dose and time dependent. So we often will try not to run a propofol drip for more than a couple of days in the ICU. Precedex obviously is very helpful. It is a good general drug to use. It seems to be less deliriogenic. The important thing to remember is it's not sufficiently amnestic to use as a sole agent. So in particular, if you have somebody who's on neuromuscular blockade for their ventilator dysynchrony, that's not a good patient to treat with only Precedex. And then obviously, we tend to get by with it always more than I think we can, but it has the potential to produce some hypotension and bradycardia. Midazolam fentanyl is kind of the old standard cocktail. Benzos are highly deliriogenic, and so most of us really have moved toward trying to avoid benzos to the extent that we can. But a regimen of midazolam fentanyl, when you're running infusions and not bolusing, is very friendly to the blood pressure and causes less hypotension. So if you have somebody who's in profound shock that you need to sedate, that's a reasonable choice. You can get tachyphylaxis with fentanyl. So if you're worried about that, or you've run it for a little while and your dose keeps going up and up, it's probably a good idea to think about substituting Dilaudid or morphine because they're water soluble and have less context sensitivity and less tachyphylaxis. Ativan infusions can be substituted for midazolam. The problem is it's hard to titrate very high, and at doses greater than about 4 milligrams an hour, the propylene glycol diluent that's in some Ativan preparations can cause a metabolic acidosis. And then ketamine obviously is a useful adjunct. There's some risk of sympathetic stimulation and cardiac issues with using ketamine in patients who are in shock, although it's also sometimes a good choice because it doesn't lower the blood pressure. And in this context of worrying about secretions and aspiration and aerosolization of secretions, you remember that ketamine can increase people's secretions. One thing that we often do in the ICU is provide a bunch of other adjuncts. Obviously, it's important to think about multimodal analgesia. A lot of patients who are in the ICU for respiratory distress may not have had a surgery, so they're not going to have as much pain, but multimodal analgesia is useful, especially for invasive procedures that can be painful. We use melatonin, which may help promote more normal sleep and is less deliriogenic, but has also not been shown to be that effective in studies. Antipsychotics are another treatment we use frequently. It's important to remember they're for behavior control and symptom management. They don't prevent delirium, although there was some hope that they would. And the main side effect of those drugs is that many of them have the potential to cause QT prolongation, so they should be dosed carefully. We sometimes use Marinol for those these days, especially in our state, who have very heavy Marinol dependency. Nicotine replacement is controversial. Most people don't use it in the ICU because of its potential for vasoconstrictive effects, but if somebody's withdrawing from nicotine, that can also contribute to agitation, so that's something to consider. Sleep aids have long been used, but these are generally thought to be pretty deliriogenic, so most of us try to avoid them, but if you're struggling and we're dealing with drug shortages, it's something to consider. Alternative strategies, we're anticipating that one of our major problems with high patient volumes in the COVID-19 setting is going to be running out of drugs that we use for sedation. So a couple things to think about: consider oral dosing of meds, Ativan, opioids, other barbiturates and benzos can be dosed orally. We don't use barbiturates that much anymore unless we're trying to put somebody into a barbiturate coma, but it's an important drug to think about. We have phenobarbital and pentobarbital at our disposal. Pentobarbital is obviously very long lasting. They can cause bradycardia and hypotension, and they actually at high doses will cause poikilothermia and temperature dysregulation. IV scopolamine is something to think about. It's a strong amnestic, which has almost no effect on the blood pressure. It's kind of a last line, and it's not something you can run as a continuous infusion, but something to think about if you have profound shock in somebody who needs to have an emergent procedure, for example. Droperidol has gotten hard to find, but can be used basically to create a sort of anesthetic-like state in higher doses. It obviously has a high risk of QT prolongation and torsades. Etomidate has not been used much anymore except for RSI because of its potential for adrenal suppression. But it's important to remember that it can be run as an infusion if you don't have anything else. And these are all risk-benefit analyses where you have to weigh the risks of the side effects versus the need for sedation. It's also important to remember that in a non-intubated patient, etomidate can be emetogenic. And then, if we end up using the ORs as ICUs, we should at least consider in the setting of a drug shortage using a low dose of inhaled anesthetics. The problem with that is that does require one-to-one continuous monitoring. So getting back to the situation at hand, in the ARDS that accompanies COVID-19 and the respiratory distress more generally, there are anecdotal reports, including from our center, that these patients have high sedation requirements. So that's something to keep in mind. And ARDS in general may require very high levels of sedation in order to diminish work of breathing and ventilator desynchrony. And then the other thing to keep in mind always is that severe ARDS may require neuromuscular blockade to limit desynchrony, and so those are patients that you want to make sure have some amnestic on board. All right, and I'm going to stop there because we're running out of time. I know we've got a lot of folks to get through. I'm going to look real quick at the questions.
I'll go ahead and get started while Ben.
We can answer the questions at the end if you want.
Yeah. So I'm going to talk about acute respiratory failure and mechanical ventilation 202. So the important part, I think, of what I'm going to say is this applies obviously to COVID, but also applies to all types of acute respiratory failure. So at its basic, our goal here is really just to maintain oxygenation and ventilation, and then avoid VILI, which is ventilator-induced lung injury. So Our most current understanding of this is it's caused by volume trauma and analect trauma, or really that non-physiologic stress or shearing of those alveoli. So probably the most important thing I'm going to say to you this morning that we've learned from ARDSNet and ProSiva trials is that the most important thing we do in the ICU to avoid this ventilator-induced lung injury is you need to maintain our tidal volumes less than 6 to 8 milligrams per kilogram, again, of predicted body weight. We've been doing this in the OR. That's on the cards that we have at the bedside that Anna produced. And then maintain our plateau pressures less than 30. So again, as I go through these other concepts, just keep that in the back of your mind that needs to always be our mainstay of mechanical ventilation treatment as possible in these patients. So when we talk about acute respiratory failure, it really dichotomizes out into two things, hypercarbic and hypoxic. Certainly patients can have both. Hypercarbic acute respiratory failure, the two takeaways for you is number one is this is usually not life-threatening. That's going to be very different from the hypoxic acute respiratory failure. And number two, what we've learned in critical care is that we really ignore the PCO2 and titrate in ventilation to a pH that's greater than 7.15 to 7.25. There are some people that we could say we'd even be more liberal on that use and go down to a lower pH, but for the most part, persons would all agree on that goal. So how do we do that? Again, important that we maintain those lower tidal volumes and lower plateau pressures. Because we can't increase tidal volumes, then the way that we're going to increase ventilation is we're going to increase respiratory rate. And in most of our patients, a respiratory rate of 25 to 35 is well tolerated. We do need to watch for auto PEEP. That's by far probably the most dangerous thing that we are going to see in the ICU when we have patients with hypercarbic acute respiratory failure. Again, I think as this group's aware, increased risk with obstructive pulmonary disease. You can treat that by decreasing your tidal volume, your respiratory rate, or changing your IDE ratio. So just as an example, because I think we don't see as much auto PEEP in the OR because our inhaled anesthetics usually treat a lot of this obstructive disease. If you look on the left, the flow time waveform, you'll see normal. Again, our flow should come back to zero, should come back to the baseline before that next breath is being taken. When you have auto PEEP, again, that next breath is going to trigger before flow comes back to baseline. On the right, if you're looking at a flow volume loop instead, you're going to see the same thing. So again, that next breath is initiated before the flow gets back down to zero. Just another graph, actually just taken right off one of our mechanical ventilators. Again, you'll see that baseline flow does not return. So acute hypoxic respiratory failure. Again, our goals here, really the lowest minimal SpO2 and PaO2 without complications is not very well studied. You can imagine what would happen if we tried to do that trial. So what we know and what we sort of devised is that we think a SpO2 greater than 85 to 88% or a PaO2 greater than 55 to 60 is a safe baseline to maintain our patients. We do use PF ratio as a criteria for ARDS, and Sam is going to talk about this in just a minute, but it's not something that we actually really follow clinically day to day. If you're looking at what we follow clinically is oxygenation index, a lot of us follow. Again, this is going to use mean airway pressure, which I'll talk about in a second, but this is something that you're going to have to utilize the ventilator to calculate to be able to use. So when we talk about hypoxic acute respiratory failure, the two classic variables, FiO2 and PEEP. The third variable that we talk about, I think much more in the ICU than in the ORs, is mean airway pressure. So that, again, is the area under the pressure time curve. The good part about a hypoxic respiratory failure is whether you're treating ARDS from COVID, ARDS from trauma, or another etiology, or really severe hypoxic respiratory failure from pulmonary edema, a lot of the basic concepts for mechanical ventilation are going to be the same. So these are all the ways, again, that we can increase mean airway pressure. The three I'm going to talk about quickly are these. Optimal PEEP is one of our holy grails in the ICU. It's been very challenging within ICU literature for the past 20 plus years to figure out exactly how we find optimal PEEP. Again, what is our goal? Our goal is to improve oxygenation, but also to avoid that lung injury. If we have too much PEEP, you'll cause overdistension and injury. if we have too little PEEP, you'll cause this hypoxemia and the same lung injury. I think important thing for this group to know is that as of yet, we have no single method of PEEP titration that's really been shown to improve outcomes over any other modality. The thing I would tell you is I think several of you probably have read about open lung strategy, which is really high levels of PEEP. And we've learned now over the past couple of years that this high PEEP open lung strategy does not appear to show any benefit. So my sort of expert advice for how we locate optimal PEEP, number one, and I'll show you in a second, I think Sam will talk about ARDSNet as well, but we'll use the ARDSNet low PEEP scale. Or number two, we can titrate it in by driving pressure, and I'll review that in a second. So again, this is the ARDSNet trial that was published now over 10 years ago. In this trial, there are actually two PEEP scales, a high PEEP and a low PEEP. Again, that high PEEP scale has really not been shown to have any improvement in outcome over the low PEEP, and probably some complications associated with it. So I think, again, most of us can feel pretty confident of using the low PEEP scale for our patients. Just of note, even you'll see that the low PEEP scale, when you're on 80% oxygen, your PEEP is going to be 14. The other way I think we can look at developing PEEP, and if you have a little bit more time with your patient, is actually to look at optimizing PEEP based on a reduction in driving pressure. So driving pressure, again, is your plateau pressure minus your PEEP. And so what I would advise is that we basically take a stepwise increase in PEEP until your plateau pressure or your driving pressure, because again, they're basically the same, increases 1-to-1 with PEEP. So the best examples, or the best way I think I can teach this, is just to give examples. And so if you look at patient number one, they're on a PEEP of 10 and they have a plateau pressure of 20. So at this point, again, their driving pressure is 10. If we increase their PEEP to 14 and their plateau pressure doesn't change, then you're seeing that now the driving pressure is 6, so it's actually reduced. And so what you're seeing there is that we're recruiting additional alveoli to help improve oxygenation. In the second example, you have our same patient with a PEEP of 10, a plateau pressure of 20. Now we again increase the PEEP from 10 to 14, and you'll see plateau pressure now increases, but it still doesn't increase at 1-to-1. So the plateau pressure at 22, the calculation for driving pressure is going to be 8. So again, you're still getting lung recruitment. So that's going to differ from the third example, where again, same patient, PEEP of 10, plateau pressure of 20. Now your PEEP is increasing by 4, and your plateau pressure is increasing by that same number, by also 4. And so in this example, you're seeing overstretch, and again, there isn't additional recruitment of the alveoli to improve oxygenation. The other part, and I think this is just as important as optimizing your PEEP, is that when you change between two levels of PEEP, you have to utilize lung recruitment maneuvers. So lung recruitment maneuvers, I think, are something this group does daily in the OR. We typically talk about either 30 centimeters of water for 30 seconds or 40 centimeters of water for 40 seconds. Again, when you do these, very typically, you'll see initial hypoxia, but then it should obviously get better. The thing you do have to watch for, especially in these critically ill patients, is hypotension. So just an example of why these recruitment maneuvers is so important. So if you take a look at this CT scan, or the study from a CT scan, so you'll see a patient in A. That patient's on 0 PEEP, and you see we just increased their PEEP from 0 to 11. And you'll see that actually overall, hopefully you guys can see this from your computers, is that the change in lung recruitability is very minimal. So if we take that same patient and now we give them a recruitment maneuver, again, 40 centimeters of water for 40 seconds, and we put them on that same level of PEEP, and now you'll see, especially on that, on the right side, that the lung recruitment has improved considerably. So the other way that, again, we can increase mean airway pressure is by titrating our IDE ratio. Again, in the OR, we can go from 1-to-2, 1-to-1 to 2-to-1. Our OR ventilators will max out at a 2-to-1, but our ICU ventilators will actually let us go to a much more severe inverse ratio. Similar to treatment with acute hypoxic respiratory failure, when you're increasing the IDE ratio, you're spending more time in inspiration and less time in expiration. you do have to be careful for auto PEEP. So the last thing, the ways that we can increase mean airway pressure and improve oxygenation in our patients is by using a decelerating inspiratory flow pattern. So again, the decelerating inspiratory flow pattern will help us to improve oxygenation by improved VQ mismatching. And you'll see here on the diagram, on the left-hand side is volume control ventilation, and on the right-hand side is pressure control ventilation. So on the left-hand side there for flow, you see with volume control, we have a consistent flow, whereas pressure control, you're seeing decelerating flow. So that decelerating flow pattern will improve your oxygenation. The good thing about this decelerating flow is that it is, again, the mainstay for what are basic settings now on both our OR ventilators, which is where we use, again, set at PCVVG, and also our ICU ventilators or Hamiltons, where we use APV. So these are all types of ventilator settings where, again, you're going to see that decelerating flow. So just as an example real quick that I took some images from the OR, what it looks like. So again, on the left-hand side with volume control ventilation, if you look on the red there, that's the flow, is going to be constant flow. Whereas on the right side with pressure control ventilation, you're seeing decelerating flow. I now flip forward to now pressure control is on the left, PCVVG is on the right. On the left, you're again seeing decelerating flow with pressure control. And on the right, even though it's volume guaranteed, even though you're setting a tidal volume, you're still going to see that decelerating flow that should improve oxygenation. The last slide I will show you real quick, again, is that we utilize some what I would call advanced mechanical ventilator modes in the ICU. The terms, these are sometimes used, again, depending on manufacturer, bilevel, biphasic positive airway pressure, not BiPAP, APRV. So really what these are is extensions of pressure control ventilation with now very severe inverse ratio ventilation. So 6-to-1 to 8-to-1 to 10-to-1 ratios of I to E. If you do see these ventilation modes used, and again, depending on the type of ventilator, oftentimes you'll see a change in pressure set, pressure high and pressure low, and time high and time low versus driving pressure that you'll see with pressure control ventilation. The reason that we can do this in the ICU, and again, you can only do this with ICU ventilators, is that it has something called an active inspiratory valve, which allows spontaneous breathing during the inspiratory cycle. And this spontaneous breathing is where you're getting your ventilation. So again, this isn't something that you're going to use on a paralyzed patient. And again, because we don't have that valve, because we can't do these IDE ratios, is not going to be something you'll be able to do with an anesthesia machine. So just as a takeaway, again, maintain your tidal volumes less than 6 to 8 cc's per kilo predicted body weight. Keep your plateau pressures less than 30. Titrate ventilation to a pH of 7.15 to 7.25. That PCO2 is not important. Watch out for auto PEEP. Try to keep your SATs just above 85 to 88% or a PaO2 greater than 55 to 60. We don't need to shoot for anything higher than that. We talked a little bit about optimal PEEP titration. Again, it's very easy and I think very reasonable to just use that ARDSNet low PEEP table. You must utilize recruitment maneuvers when we're changing levels of PEEP if you want to recruit the room, recruit the lung. And then finally, utilize mechanical ventilator settings with decelerating inspiratory flow patterns. So PCVVG in the OR, or if you're seeing patients up in the ICU on the Hamilton ventilators, it's APV. Thanks. No, I can't hear you. I think you're still muted.
Can you guys hear me now?
Yeah.
All right, sorry about that. So I burned minutes that I don't have. So I'm going to talk about ARDS pathophysiology classification, and then talk about advanced therapies, neuromuscular blockade, prone positioning, and inhaled pulmonary vasodilators. So the Berlin criteria established in 2012 really just codified a lot of things that we already knew, but are sort of the agreed upon definitions of ARDS. So respiratory distress within 7 days of known clinical insult, or new or worsening respiratory syndrome symptoms. These are going to be associated with bilateral opacities consistent with pulmonary edema on chest radiographs or chest CT. Previous definitions are really hammered that there not be cardiogenic edema as well, although that can be a concomitant finding. These categorizations are important because this is what we use to really decide what therapies to push forward with. So when we're classifying ARDS, mild is a P to F ratio or PaO2 to FiO2 ratio of 200 to 300. That confers a mortality of about 27%. Moderate ARDS with a P to F of 100 to 200. And then severe ARDS with a P to F of less than 100 millimeters of mercury confers a mortality all the way up to 45%. Of note, this is always with a minimum PEEP setting or CPAP of 5 centimeters of water. So we're not going to talk about the pathophysiology very in depth, but just to know there's really 3 phases of ARDS. The first being the exudative phase, which is really our inflammatory response characterized by an innate immune cell mediated damage to the alveolar endothelial cells, and then accumulation of really protein rich pulmonary edema. There's microvascular injury that goes along with this as well, microvascular coagulation. The second response, the proliferative phase, is really the repair and restoration of integrity of the endothelial membrane. Once that integrity is reestablished and we're able to reabsorb some of that alveolar edema, then you can get that function back. The fibrotic phase is really the most feared phase of ARDS that we're always hoping to avoid. Not all of our patients reach this, but essentially when the lung starts to scar down, this is really where our interventions become significantly less useful, and it confers a higher risk of mortality and prolonged mechanical ventilation. So try not to retread too much ground that Dr. Brainerd always covered. First and foremost, treat the underlying cause just like any other pathologic process. And then, basic tenets of critical care: avoid doing further harm. So limit further lung injury by volume trauma. Some people will hear it talk about what's called the baby lung theory, which is essentially that only a small part of the lung in ARDS is actually able to participate in gas exchange or ventilation at all. So we may be over-distending even at low tidal volumes. Barotrauma, which of course in anesthesia we're all very familiar with. Atelect trauma, which Dr. Brainerd already talked about. Problems with under-PEEP patients with the alveoli opening and closing, and then biotrauma for our inflammatory cytokines. Really, the mainstays of therapy for ARDS are the ARDSNet ventilation strategy, low tidal volumes and lower high PEEP scales, conservative fluid management, either through diuretics or just restriction, and then supportive care. More advanced therapies are things that we may be actually a little more familiar with in the operating room, the first of which being continuous neuromuscular blockade. So this trial in 2010 really looked to codify recommendations that had already been made through meta-center analyses, but comparing cisatracurium to placebo. And really, this is early onset ARDS, so within 48 hours in patients with a P to F less than 150, saw a significant mortality reduction and no increase in ICU-acquired paresis. This was all included in the 2016 Surviving Sepsis campaign. Now, this has recently been challenged by a reevaluation trial in 2019 that looked at cisatracurium with heavy sedation versus no paralytic and light sedation. Similar enrollment criteria, but the argument was, hey, maybe this heavy sedation is actually what's causing problems. There was no difference in mortality, no change in secondary outcomes, but a higher rate of cardiovascular events and ICU-acquired weakness. So you'll hear a lot of our pulmonology colleagues really arguing that we shouldn't be paralyzing patients. The big caveat to this is the proning rates in this trial were significantly lower than the Accurasis trial. And we know that that's one of the most beneficial interventions we can do. So generally, we are still recommending neuromuscular blockade in that very low P to F category. That's something to always consider, especially if you haven't found a need to prone the patient, that you may be okay with lighter sedation and avoiding paralytic with similar effects on mortality. So to move into prone positioning, whereas we typically look at proning as a way to, increase surgical exposure and facilitate things in the operating room and the ICU, we really try to utilize the physiologic benefits. So theoretically reducing overinflated lung area, promoting alveolar recruitment, and a more even distribution of that transpulmonary pressure that Dr. Brain was referring to. But really the big thing is relief of pressure from the heart and other ventral intrathoracic structures. So I thought this diagram was really instructive. So looking at a patient supine with no heart, prone with no heart, you can see that, really the spinal cord and the spine inhibits the total availability of alveoli, but of course, all of our patients have cardiovascular systems. And so with that heart in place, there's significantly less real estate in a patient in the supine position as far as areas that are well ventilated versus the prone position. This was all supported by the Perceiva trial in 2013, proning with paralysis versus usual care. The paralysis rate was actually very similar between these groups, 51% relative reduction in all-cause mortality. And again, this made it into the 2016 surviving sepsis guidelines as well. So really considering proning these patients, ideally within 36 hours of developing severe ARDS, patients with a P to F of less than 150. Now, one of the questions that comes up is proning is a little bit different in the ICU than it is in the operating room, mainly in that the RTs and the nurses are doing most of the heavy lifting. Our nurses are very attentive to pad bony prominences, making sure that we're not running into any sort of plexopathies or other nervous system issues, keeping patients from reverse Trendelenburg, and then turning and repositioning the head every hour. We don't have our prone views like we have in the operating room. Generally, the patient's head is turned to the side, and then you'll see the swimming position so we can maintain a little bit of range of motion because we're not worried about a surgeon standing by the side of the bed, but also making sure that we avoid plexopathies from prolonged positioning. Just as a brief note, we'll talk about inhaled pulmonary vasodilators, some medications that our cardiac, liver, and ICU docs are a little more familiar with, or at least see quite a little more often in the operating room. The idea is that, inhaled nitric oxide or inhaled epoprostenol can improve VQ mismatch by selectively dilating the pulmonary vasculature that's actually participating in gas exchange. The short story is the good news is this improves oxygenation and PA pressures. The bad news is there's really no improvement in 30-day mortality in these patients, and it might be harmful. So we generally reserve this as salvage therapy in folks that are not doing particularly well. All right, I'm going to move on. Sorry, that was pretty fast, but hopefully we can answer questions afterwards.
Okay. Hey, it's Josh Dewan. So I'm going to talk about, we're getting more into the experimental realm a little bit, the use of anesthesia machines as ICU ventilators. I want to give credit to Sarah Elber, who just had a baby on Friday. She did put together most of these slides. I just changed them a little bit and accepted for her to give this talk. So let's see. There we go. As you know, governors around the country are asking for ventilators to be made, and we're looking at all options available to enhance the number of ventilators we have in the ICU. One relatively easy solution is anesthesia ventilators or anesthesia machines, and we'll talk about why there's some differences and challenges associated with those. Okay, so the FDA actually gave emergency approval to use these devices as ventilators, and basically, for time purposes, we'll move through a little quickly, but they've approved a variety of different ventilator systems, including BiVAP machines, transport ventilators, home ventilators, and anesthesia machines for this purpose. Now, one of the biggest differences, and this is going to be highlighted in, is manpower. So folks who are ventilated with an anesthesia machine, whether in the OR or in the ICU, require rounding by an anesthesia provider. And that could be a physician, that could be a CRNA, or it could be an AA. But the most important take-home point is that it will require as frequently as every 1 hour rounding with some more higher level maintenance occurring less frequently. Okay, so here are some of the key differences between the two machines. So the anesthesia machine humidifies passively. It uses oxygen for the pneumatically driven ventilators as opposed to pistons and electrical components for the ICU ventilator. And then the remaining four things, CO2 absorbent, scavenging, volatiles, are of course very unique to our anesthetic machines. The advantages of the ICU ventilator are it actively humidifies the air, so decreasing secretions and helping keep lungs more compliant, and then obviously less oxygen consumption. So the difference being that machines that require oxygen to drive the pneumatic systems, which is most of our anesthesia machines, actually use more oxygen. And we still don't have a great idea of our entire oxygen capacity if we were to have, for example, a 24-bed ICU powered completely with anesthesia ventilators. The last I heard, engineers and institutes are working out this issue to figure out if our oxygen supply is capable. There have been reports of hospitals, particularly in New York, that have been running low or running out of oxygen because of these issues. So something that we're keeping in mind but still don't have definitive answers to at the moment. And then there's the scavenging system. So this is really important to not deliver excess PEEP or cause barotrauma to our patients. And in an ICU environment, the recommendation would be more likely the closed than the open system. So instead of disconnecting it completely, you just take it off and add proper viral filters in place. This takes a little bit of retrofitting by Biomed, in addition to some other things we'll talk about in a second. But it's very easy to introduce barotrauma without this in place, or at least unrecognized barotrauma. So that's one of the issues that we're working on dealing with the anesthesia machines in the ICU. So this came up, a couple people asked questions about volatile anesthetics, and can we use them as sedatives? Because we're using so many sedatives intravenously in the ICU, could these supplement or at least alleviate the burden of some of our drug shortages? The short answer is maybe, but there's no evidence for their use long term. We don't know what happens if somebody is on, for example, sevoflurane for 2 weeks. That data just does not exist. So right now, the recommendation is to not use them, and really only as a last resort. So we are going to be removing all of the vaporizers from the any anesthesia machines that are used as ventilators in the ICU for the time being. Okay, and then there's CO2 absorbance and fresh gas flow. So there's really two algorithms or paradigms you could use to retrofit this device for the ICU. So the preferred method would be lowering the oxygen supply and the CO2 absorbance. So this would allow for lower fresh gas flows. It's still, regardless of the method chosen, requires that fresh gas flows are increased above minimum ventilation every 4 hours. That's part of our maintenance checklist, which we'll go over in a minute. That helps dry out the components. So essentially, excess humidification that can occur with long-term use of the anesthesia machines can cause some issues with the electrical circuitry of the machine, which is why you need to essentially dry it out by increasing fresh gas flows every 4 hours. And that's for a brief period of time. This would be part of our anesthesia staffing model. The alternative paradigm is going to be keeping fresh gas flow higher. Of course, that uses much more oxygen supply. And we are not 100% certain at the moment, at least at Anschutz, if our ICUs could tolerate this on a wide scale in the ICUs. Okay, so how do we conserve oxygen supply? Well, here are the differences put out. It doesn't seem like a lot, but when we're talking about multiplied by 24 per ICU, potentially if we double up rooms, that's 48. I mean, you're talking about a significant increase in flow, which was not initially engineered into the system. And so the ways that we can get around this, one potential method is by switching to compressed air, and all of our ICUs have compressed air circuits as well as oxygen circuits. It does require a significant amount of time to convert the machine, something on the order of 4 to 6 hours is what we've been told. and then it only consumes the oxygen required for fresh gas flow, similar to our ICU ventilators. Our biomedical engineering department is working on these retrofitting procedures at the moment. The other issue is we don't know if we have enough air pressure to run these in all of our ICUs either. So the same issue applies with oxygen, just switching one problem for another. Okay, and then there's humidification. So the FDA strongly encourages that any anesthesia machines that are used as ventilators in the ICU would keep their passive humidification system, which we already use in the operating room. The ASA and Anesthesia Patient Safety Foundation also recommend this approach. So what they also recommend is that these are not intended, the HMEs that we use, to be used for long periods of time. They're meant for the length of an OR case. What they recommend is saying, well, this is an emergency, we're going to use them longer than necessary. So a lot of caveats and basically using things outside of their intended spectrum is what we're encountering, and so we have to make some of these adjustments. And so they're saying up to at least a week of using these HMEs. Now, our ICU ventilators use an active system, which could also be retrofitted to the anesthesia machine. But again, you run into the condensation issues, which can not only obstruct valves and flow, but can also damage the internal circuitry, as we talked about. It decreases the efficiency of our CO2 absorbent. I mentioned the electrical failure. So again, using these heat and moisture exchange filters for up to 1 week is encouraged. So here's a summary of what we would need to do as a department if we're utilizing these machines. We would need basically 24/7 staffing by a responsible anesthesia provider. Again, that could be any level of provider, because the respiratory therapists are not nearly as familiar with our devices. While they know the mechanics of mechanical ventilation and are able to titrate PEEP, FiO2, and ventilation, they are not nearly as familiar with our systems. Now, the biggest issue is the hourly rounding. So that is going to be why we need the 24/7 anesthesia staffing. We're not using volatile anesthetics as of this time. Going to disconnect the scavenging system, use the passive humidification, and a full anesthesia machine check every 24 hours if possible. That obviously requires, in ventilated patients, disconnecting them from the circuit, having some sort of alternative ventilation, whether that is bag mask, ambu bag, or some other method. So here is the checklist. You can find this at the ASA and the APSF put together. Note that there are a bunch of hourly issues, some that are Q4 hour, particularly increasing fresh gas flow, and then the 24-hour full anesthesia machine check. And here is their full setup for your reference. That's it for me. We'll hand off to Martin.
All right, I hope everyone can hear me. I'm just going to talk about another experimental approach to the shortage of ventilators, and that is splitting vents. This is something which Leslie has been talking about last week already shortly. This is something which has been described in the literature pretty well in the early 2000s when anthrax attacks, the first SARS epidemic, and natural catastrophes like Katrina came up. But obviously now it's something which comes back into fashion, mostly because we have a shortage of ventilators. Basically, just a few weeks ago, multiple societies have brought out a joint statement claiming that that they would advise against splitting vents because there were some safety concerns, which are listed on this slide here on the left side. However, like at certain places in Bergamo in Italy, and even in New York now at Columbia, the necessity and the shortage of ventilators basically forced providers to go ahead with this technique anyways. And
specifically Colombia has done a pretty good job of explaining how they would mitigate those concerns from the big societies. So this is my busiest slide, but I'm going to go through this relatively quickly. One of the obvious concerns is the risk of cross-contamination. So obviously, if you hook two patients up to the same ventilator, you want to make sure they're definitely tested positive for COVID, so that there are no POIs. You want to make sure they don't have any additional super infections. And you're going to use a redundance of filters. We obviously have our heat and moisture exchanger, which has an antimicrobial filter integrated into it, but you will also separate both circuits by separate HEPA filters. And if one of the two patients actually does catch an additional infection, you basically have to treat both patients for that infection and ideally separate them from each other again if it is possible. Another really big concern from all these societies is that patients get potentially hypo/hyperventilated. This assumption is made based on the fact that someone has chosen the volume cycled mode on the ventilator. You have to imagine if the compliance of one patient is worse than the one from the other, the one with a better compliance is going to see most of the tidal volume gets hyperinflated, while the other patient probably does not get sufficient ventilation. And this can obviously be exacerbated if one of the two patients has an acute deterioration like a pneumothorax or a mucus plug. Another big concern is that you're not going to detect it early enough because you have this one respiratory monitor, which basically gives you additive values of both patients for the tidal volume and the minute ventilation. And the way you can mitigate those risks are that you basically pair patients appropriately, similar to their vent requirements, to their lung compliance. And you obviously have to switch them to a pressure-controlled ventilation mode, so that even if one of the two patients deteriorates, that the other patient still sees an appropriate tidal volume while you take care of the deteriorating patient. Ideally, you will also want to have separate freestanding respiratory monitors available for each of the two patients, so you can monitor the tidal volumes independent of the machine's respiratory monitor, and patients should have separate capnographies as well as frequent ABG draws. Another big concern of those societies is how the patient ventilation, how the patient interacts with the ventilator, especially if one of the two patients is driving the ventilator with an increased respiratory rate, which would then potentially affect both patients. And for that reason, you have to make sure that both patients are basically paralyzed. And now you might wonder how you get these patients off if they're both paralyzed. How can you individualize the management in a way that someone actually can be weaned off the ventilator again when it comes to the time? What a lot of places have done, including New York, is that they have put one rescue ventilator next to a bunch of other dually vented patients, which can be used to take one patient off at a time to wean them off the ventilator. Another big concern is that patients can potentially share pendeluft, so they basically share gas, which gets moved from one patient to the next. Besides the cross-contamination risk, another risk is that you basically increase the dead space ventilation. And one of the solutions to that is that you basically try to minimize this approach to two patients per ventilator so that the tubing and the additional dead space is minimal. A lot of the societies have mentioned that there's a certain ethical concern in that regards, that they would actually recommend, if you have two patients who need a ventilator, to basically triage, so potentially makes one patient comfort care and support the other ventilator if you're short on ventilators. Now, if you have two young patients with not many comorbidities coming in at the same time, and you can probably both save their life if you would basically support them for a couple of weeks on a ventilator, you can probably turn this argument around. But whatever you do, you have to make sure that the institution is basically behind your approach and has approved your protocol for this mass crisis. So this is the setup from Colombia. You basically see that everything is set up twice. Besides two circuits, you need two T-pieces, two connector cuffs, and two antimicrobial filters. And the setup is relatively easy. You basically attach those T-pieces to the connector cuffs, you hook up one microbial filter to both of those T-pieces. And then on one T-piece, you're going to connect both ends of the inspiratory limbs, and you do the same for the expiratory limbs on the other T-piece. And then hook it up to the outlet at the ventilator. And you can see how this is supposed to look like on the left side once it's all done. And there are certain variables. You can basically see on the left side how you have a humidifier, a heat and moisture exchanger, as always at the tip, which also functions as an antimicrobial filter, as well as the HEPA filters closer to the machine. You can add multiple patients, as you can see on this picture to the right, but the more complex you make the system, obviously, the higher it is at risk for something going significantly wrong, especially at the day and age where we are short not only on materials, but also on personnel. One important thing I want to emphasize is that we have been cooperating with a group of talented engineers and people from the private industry, which have helped us to produce some of these supplies, such as the connector cuffs and T-pieces, by 3D printing. So even if we run short of these devices, there's a lot of support in the community to help us with that. And I can just encourage you to visit the homepage here and consider donating to these very talented people who actually do this on their free time. Before you even consider hooking up 2 patients to 1 ventilator, obviously you have to make this regular safety check first. And this would also include now that you hook up 2 test lungs to both of the outlets of your circuit to basically simulate how it would work if you have 2 patients hooked up. You basically want to switch the vent to pressure controlled ventilation and then make sure that everything works well. You should have a separate respiratory monitor hooked up to both patient outlets, as emphasized here. This is the NM3 monitor. You want to make sure that both test lungs basically have the same tidal volume. You could even simulate what would happen if one of the 2 patients deteriorates by pushing your hand on one of the test lungs. This could, for example, like play through the scenario of a pneumothorax, and you can basically check if your other test lung still sees the full tidal volume. The next step is that you want to pair the right patients together. As I mentioned earlier, you want to make sure that patients have about the same requirements on the ventilator. That includes the driving pressure, as well as their respiratory rate, but also their PEEP and FiO2. And you want to hook up patients to the same ventilator, which have about the same settings. You can see here from the protocol from Columbia that there's some wiggle room to the left and to the right, but they should overall match together. And then you can basically, for example, set up 4 ventilators with different settings. Each ventilator has 2 patients attached to it. And you want to keep one of ventilators as a rescue vent if something bad happens, or as a weaning vent or transport vent if that becomes true. Before you hook the patients up, you want to make sure that you know what each patient's settings are on the separate vent. So you basically want to switch them to a deeply sedated state, paralyze them, put them on pressure control, and then take their tidal volume and minute ventilation and basically add it up and put it on so that you basically can change the alarm settings on the ventilator you intend to use for the dual patient ventilation. I will emphasize at this point is once again that it's very important that you have separate individualized monitoring as well, so you don't purely rely on this one big respiratory monitor. But you should also hook up freestanding respiratory monitors at the lure connector of each patient, and also do tidal CO2 and ABG monitoring. Finally, and I'm probably already over the time, I just want to emphasize that this is purely experimental, that this has not been approved by our institution yet, that no one should try this out before we get into a situation where we need it, and that will hopefully never be the case. But if we get to that point, we have to make sure that we have an FDA emergency use authorization submitted and approved, as well as that our institution is actually behind the utilization of this technique and has approved our protocol as well. Whatever we're talking about, you have to consider that for us providers, both sides kind of have their disadvantages. If we triage patients, which we were able to usually help if we would have had additional vents, there's a certain liability risk to that. But on the other spectrum of things, using a non-FDA approved technique such as dual ventilation is also something which brings obviously some liability. So if you start a technology like this, you want to make sure you collect the data right away so you can pick up on any benefit or harm and abort or expand your efforts depending on what your results are. And that's it for me.
If there's any other questions from the audience, please let us know. We'll try to continue to answer questions that come up on the webinar chat. If not, thanks everybody. We really appreciate it.